wasn't upset about that. They were coming in for reflux. Okay? So, that constipation varies. And in a Parkinsonian patient, you can have just, constipation would just be a mild nuisance. It's just kind of, it doesn't really impact your life. But in others, it's a chronic problem, can really alter the lifestyle. When you're really constipated, it can affect absorption of your medicines and effectiveness, because if things aren't moving down, you're taking those pills, they're going nowhere, okay? So, you have to, you're going to get the gut moving. What really, if you have to define constipation, it's less frequent stools, less movement, or more difficult to pass stools, and looking at less than 3 per week. That's the average. You go 3 a day, 3 per week. But when you're outside that 3 per week, that's considered constipation. So what are the causes of constipation? Well, there are many causes, but in Parkinson's disease, it affects the autonomic nervous system. And the autonomic nervous system just takes over. It's helping you to sit here and breathe right now, your heart to beat, and your digestive tract to move. So Parkinson's affects that autonomic nervous system and slows the digestive tract, just slows it, and that's the constipation. But other things can happen to cause constipation in the Parkinson's patient, just like in the regular person, your caregiver, your partner, drugs that you take, prescription drugs, narcotics. We have the big narcotic thing going, and they come in and they have, narcotic-induced constipation. It's like trying to get cement out, and that can happen if you take too many narcs, can't go. But iron tablets, everybody says you take an iron pill, you're constipated. And certain antacids, calcium-based antacids, like if someone comes in and tells them about their reflux, and they're taking a bunch of Tums, they go, oh, stop it, because that will cause constipation. And aluminum-based antacids, okay? So, and the drugs that you use for Parkinson's can cause constipation, like Artane. Great, if you stop the tremors, but it tightens you up, okay? And then one of the most important things that could lead to your constipation, limited physical activity. If you're not moving and grooving, the gut likes to see those abdominal muscles moving and keep you going, okay? Inadequate water intake, inadequate fiber, all of these things lead to constipation. But overall, you've got to discuss this whole constipation thing with your doctor, okay, with your doctor, because someone who's severely constipated or has a family history of colon cancer, they need more than just, sort of a talking to. They need to be investigated. Things need to be looked at. Okay.
Thank you. We're going to go now into the audience for questions and answers. Do we have people with microphones, Tony? Okay, so raise your hand and someone with a microphone will come over. And again, any question, it doesn't have to be about what we've just talked about. So if you don't have any, I will ask the panel. We have somebody over there and over there. Okay.
What does she suggest?
For constipation?
With somebody with Parkinson's who feels
Okay.
So the question, I'll just relate the question. So the question is, what is suggested to treat constipation in Parkinson's?
Okay, the very first thing is what you would do with anyone who walks through your door and says if they're constipated. Are you active? Are you moving? Are you doing something? Or are you just sitting at home? Okay? You need to get up. You need to move. I am very serious about that. Swim, walk, weightlift, Pilates, whatever. Do something. Your abdominal muscles, getting those moving makes the GI tract move. Okay? Change your diet. If you're sitting at home eating, potato chips, it's not going to work. You need some more fiber in your diet. You need fruits, and the fruits like berries and fruits with skin, apples, pears. You need to get all of that going. Just more fiber in your diet, whole grains. And then other things, you need to drink water, 6 8-ounce glasses a day. And not 6 8-ounce glasses of beer or wine or caffeinated drinks, because they cause dehydration. They actually make it worse. You go chug a few beers, it's not going to help you. Okay, you need to go with water. To that, and that water going through your digestive tract helps things to flow along. The fiber helps things to flow. and smaller, more frequent meals rather than eating one. You know, I have a lot of folks that, you know, they're shift workers or whatever, they eat one big meal a day. That doesn't work. Smaller, more frequent meals, it gives time for things to go down the digestive tract. Okay?
Great. Next question.
You didn't mention REM sleep disorder as a symptom or how that is related to Parkinson's.
Yeah, so we see that as the very first on that continuum. I know it's hard to read, but it says REM sleep behavioral disorder, which REM sleep behavioral disorder I'm going to let Dr. Alvarez talk about. So why don't you give us a bit of a blurb on that?
So sleep in general is not uncommonly heard in Parkinson's patients. So the simplest problem you can hear is that patients cannot fall asleep, they cannot maintain sleep due to many factors. And then if they fall asleep, then they start having symptoms of vivid dreamings, of nightmares, talking, yelling, kicking in their sleep. So all of these symptoms during their sleep can be seen in REM behavior sleep disorder. They're actually, to add to Dr. Joy's study 15 years ago, the same group of patients in Hawaii, to look at these aging agents to look for premotor symptoms of Parkinson. And REM behavior can be seen up to 15 years before the onset of Parkinson. So there's a lot of symptoms that are linked to Parkinson as the disease is advancing. 10 years or 5 years down, after the disease onset, or it can be a manifestation before the onset of Parkinson's disease. It's very challenging because the next day, these patients that don't have good quality of sleep, they are very sleepy the next day. So they may have quantity of sleep, but they don't have the quality of sleep, and so they feel tired. The more they don't want to exercise. Typically, these patients require meds. We usually send them to sleep specialists because there may be other coexisting factors that can worsen their sleep. Okay?
So REM behavioral disorder, as Dr. Alvarez said, can precede the motor symptoms. Doesn't mean you'll develop Parkinson's disease, just like constipation doesn't mean you'll develop Parkinson's disease. Can be seen in other disorders of the brain, including Alzheimer's disease, and may occur when those disorders are diagnosed otherwise. And then sleep problems in general can happen throughout the disease course. So, next question.
I'm a little bit surprised that there wasn't any mention of sense of smell loss. I know many people with Parkinson's who've lost their sense of smell. I know I lost mine about 15 years before I was diagnosed with the disease.
Yeah. It's a fancy term there. It says hyposmia. So Hyposmia, that means loss of smell. So it is in there, but so again, loss of smell can be due to many different things. Virus, smoking, head trauma, lots of different things. So it doesn't necessarily mean it's going to turn into Parkinson's, but there is some evidence to suggest the relationship between loss of smell, and most of taste comes from smell, so loss of taste as well is part of the disease. Okay, we got a question back there.
Parkinson's being a lack of dopamine, is there any food that we can eat that increases the dopamine?
I don't know if there are particular foods indicated. I tell you, I don't really have an answer for that. But if you literally, if you do increase the fiber in your diet, that will help. There are new studies coming out looking at the microbiome and patients with Parkinson's disease who have constipation as opposed to those with movement disorders and controls, and to see if there's a difference in the microbiome, if the bugs in your gut are there to help you to, you know, get those bugs going, to get your gut going. And there are also studies on fiber supplements that are prebiotics. They kind of kick the bugs in your gut to get things moving.
But to answer your question directly, so you can't eat dopamine, because dopamine, first of all, doesn't cross the blood-brain barrier. And the immediate precursor to dopamine is L-Dopa, levodopa. And so you need to take levodopa to facilitate your brain making more dopamine. And because levodopa is converted in the body very quickly without carbidopa to dopamine, and dopamine doesn't get into the brain, you'll need to take it with carbidopa. So again, There isn't a reason to take something over the counter when it's available in the appropriate dose forms and in combination. So again, to answer that question specifically. All right, we have a question right here in front.
A quick question for Jim. I was just curious about how much, if any, of the feeling was restored to his feet.
Yeah, so let me just make a comment on that. So again, the neuropathy is not part of the Parkinson's disease. So while that was a very successful story on improving the sensation, it isn't specific to Parkinson's disease per se. And so I don't want people to be misled that the neuropathy is due to the Parkinson's disease. So, and again, we'll touch upon Pilates a little later. Next question.
I had a question about the urinary problems. Is that more urinary infection, or is it control of muscles so that you have leakage?
Well, I'm going to toss this to Dr. Lee, although no, it's not his area. I'm going to let him talk about the bladder. So, in a surgical sense. So the problem is, what is the problem with the urinary bladder malfunction? So, if not, we'll bail you out. Okay.
I'm going to give a quote from Gone with the Wind. I'm an orthopedic surgeon. I know nothing about urinary.
All right. Fair enough. I'll give it back to Dr. Alvarez.
So I think urinary infection in Parkinson's disease is multifactorial. The first thing is that, of course, this is a neurodegeneration, so the neurological system is affected. The most common one would be the autonomic nervous system. Number two, Parkinson's patients don't drink enough water, so if you're dehydrated, you're more likely to have infection. And that's not just for Parkinson's disease, that's for everyone in this room. And number three, it could be many, but I'll only mention three. Number three would be lack of mobility. So if you don't move, we're more at risk for infection. So that just goes again, not just for Parkinson's disease, people with stroke, people with MS, anyone that's just unable to move, they're at risk of mobility. So an example I tell my patients is like a river that keeps moving clean, and a river that's stagnant water is more likely to be dirty.
And to add to that, it's a very descriptive answer. I'll add that in Parkinson's disease, the bladder also doesn't relax. It's stiff. So it doesn't relax as normally our bladders do, so that it can hold more urine. And since it's stiff, you feel like you have to go all the time because it can't relax to accommodate more urine. So that, in addition to the urinary tract infection issue that Dr. Alvarez talked about. Yes.
In regards to the constipation, the probiotic I have found is a wonderful remedy for the constipation and for the bowel problems, especially also with diarrhea. And I found that you need to invest in a good probiotic. Don't just get any run-of-the-mill one. They're kind of pricey for 28 tablets, I think, at Walmart. The line is like 26 bucks or something. But it's well worth it. The probiotic really does change the gut and make things a lot better.
I don't know if Jocelyn, you want to comment on that?
Well, yeah, probiotics will work, and she's right. And you just sort of take the, the kind of generic whatever. It sometimes may not work, but you sort of have to work it through and find which one works for you. I mean, I like a lime, but a lot of folks it doesn't work for them. There are others. There's Endimune, there's VSL1. All of these things help, but you've got to move, change your diet, drink more fluids, and there are all sorts of things and other things that can be used, like stool softeners, osmotic laxatives like Marilex, polyethylene glycol. That works too, But using a good probiotic will keep you along with exercise, changing your diet, drinking more fluids will keep you moving. You've got to get stuff on the top. Nothing's going to happen if you don't start moving at the top and get moving it down. You've got to move. Fibers got to go there. Everything has to be together.
Good. Another question back in the room there?
Just a comment on both issues. The constipation proofs still work. And
They work really good, but you have to be a little bit careful.
So an advocate of prunes. So.
The second thing is the bladder. Exercise is also a remedy for keeping your bladder, or your ability to not have leakage. And the old Kegels still work.
If you're going to use prunes, you can also use just prune juice, but warm it. Even warm water in the morning will stimulate your gut to work. So you can use it if you're worried about your weight. Prunes are very, but you can even just do warm water.
Question here.
Where is the question?
Over here.
Okay.
This side.
Hi.
Hello.
Hi. I guess constipation is the hot topic. I do have a question about it. I'm a speech language pathologist, and sometimes I do get asked about that. And I just wanted to double check that I am telling my patients to do the right thing. And I do recommend papaya enzymes. I don't know if that is something, I always let my patients know to tell their doctors because it's a supplement, but I know it helps with digestion and it's natural. So I just want to make sure that it was something okay to tell them dates, and papaya enzymes are my little secret for them.
When one has Parkinson's, you can also have accompanying other illnesses, like diabetes is a common one where you don't have adequate digestive enzymes. So in that sense, it kind of works. A lot of times, the digestive enzymes that you get off the shelf at GNC are not really active. They're just, they've been inactivated in the whole process. There's something good about the FDA. They make sure that when it says it does X, it does X. So, I'm not against, using the over-the-counter stuff, but I kind of like making sure that, if the drug says it does X, it does that. And when you get digestive enzymes from your doctor, for people with, insufficiencies, pancreatic insufficiencies, things like that, they work. I'm not against it, but if it works for you, fine. Check it out with your doc before you start taking stuff, particularly stuff at GNC. A lot of that really isn't all that great.
Thank you. I'm going to ask Dr. Lynn a question. We see as the disease progresses at the bottom of the little graph there, we see pain. And so I'd like Dr. Lynn to comment on how pain can affect Parkinson's disease, and then maybe any common pain problems that you see in this population.
Okay, I'm gonna quote Tony Chambers' analogy. He said, well, we have, our body's almost like, it's a multi-system, device. And so if you have just so many soldiers, and the soldiers have to go fight a war, and so you're fighting this Parkinson's illness, right? So if you're fighting, partially you're taking some of the soldiers away to fight pain, therefore your Parkinson's symptoms are going to worsen. So if you treat pain appropriately and reduce the pain symptoms, your Parkinson's syndromes and symptoms will be improved. So how I categorize 4 different types of pain in Parkinson's patients. One is obviously you may get some kind of musculoskeletal pain, and that actually precedes even the movement part of this disorder. Shoulder pain being one of the first symptoms that comes up, they become really stiff, and your shoulders become really stiff, and how do we combat that, right? It's movement again. So I usually tell my patients, motion is lotion, and if you don't move, the joint is going to get stiffened, and then it's going to develop a lot of pain, and even inflammatory responses inside of the joint. And the second part of pain syndrome, I think about neuropathic pain. And so Jim gave an example about his, I would think it's kind of diabetic neuropathy that you suffer from. But on the other hand, Parkinson's patients can have just generalized neuropathic pain from everyday life. Okay, now, face it, it's a disease of overpopulation, so you're going to have your spinal stenosis, your pinched nerves, all kinds of neuropathic pain that's associated with this aging. So your pinched nerves, how do you treat that? There's physical therapy, there's Pilates. I always tell my patients yoga, those of you who are in the audience, yoga, and so if you reduce, how do you reduce these neuropathic pain besides medications and injections? It's exercise. The third part is dystonia. So Parkinson patients, from my understanding, you get a lot of stiffness because of that lack of dopamine. And so the muscles become kind of desynchronized. So you're not balanced. So there are tightness in the muscles, and how the physical therapist will tell you, what do you do besides your baclofen and your tiazepam and your muscle relaxants? You stretch the muscles. Then your dystonic type of pain is going to be minimized. And you can go fight that, Parkinson's, and with the extra soldiers that you have, right? And the very last thing is something that is very newly described. It's centralized pain. And central pain is less than 10% of the population of Parkinson's. And it's a gnawing, kind of like deep sort of chest or abdominal pain. That's I'm sure that Dr. Parker and Dr. Vicky Alvarez can explain a little bit more. And I was reading about this. But central pain is very kind of rarely described in Parkinson patients, and it may be mistaken as dyspepsia and chest pain from cardiac sources. Of course, talk to your doc and get examined, make sure it's not cardiac or some other gastric ulcers or whatnot. But it's a very typically treated part of the pain syndrome of Parkinson's. And they do, again, encourage just moving exercise, and it decreases centralized pain.
Thank you. So one last question in this section. I'm going to ask Rocky to comment on this. So we've talked about making the diagnosis based on history and exam. So once we make the diagnosis, it's often perceived as a loss. It's a loss of our self-image, a loss perhaps of how we see ourselves in the workplace or amongst our peers. And I'd like Rocky to comment on the grieving process and how some patients may benefit by a more in-depth counseling on that.